Digoxin, a lifesaver in heart failure, can turn into a silent threat when its levels go even slightly above the therapeutic range. Imagine a patient walking into your clinic complaining of loss of appetite, nausea, vomiting, blurring vision and palpitations. As you examine the ECG, you notice strange arrhythmias. So this is where knowing the classic triad of digoxin toxicity, which comprises of gastrointestinal signs and symptoms, the CNS symptoms, the cardiovascular signs and symptoms. So this is the classic triad of digoxin toxicity, and we will explore in this session the signs and symptoms, the mechanisms and the treatment of digoxin toxicity one by one. Now let's begin with the mechanisms that are responsible for the signs and symptoms of digoxin toxicity. The gastrointestinal signs and symptoms are anorexia, nausea, vomiting, abdominal pain, cramps and diarrhea. So what are the mechanisms? The first one is stimulation of CTZ of the medulla. Direct stimulation of CTZ of the medulla can induce nausea and vomiting. Secondly, enhanced vagal tone. This is one of the properties of digoxin. It can stimulate the parasympathetic nervous system, increasing the acetylcholine, and this increases the motility of the intestine, increases the motility of the GI tract, leading to abdominal pain, abdominal cramps and diarrhea. Next one is electrolyte imbalance. Hypokalemia is common with digoxin toxicity and it can worsen GI irritability. The next one is local irritation because digoxin has a property to accumulate in the intestinal tissues. It can alter sodium-potassium ATPase pump in the intestinal tissues and this can worsen GI discomfort, it can worsen abdominal discomfort and loss of appetite. So these are some of the mechanisms that are responsible for the signs and symptoms of digoxin toxicity. The next is the cardiovascular signs and symptoms. So speaking of the cardiovascular signs and symptoms, both bradyarrhythmias and tachyarrhythmias can occur with digoxin toxicity. Bradycardia is an early sign and in severe digoxin toxicity, ventricular tachycardia, ventricular fibrillations can occur. So let's see what is the mechanism. As we know that the primary site of action of digoxin is the sodium-potassium ATPase pump. So digoxin inactivates the sodium-potassium ATPase pump, leading to increased concentration of sodium. Now, to be noted that the sodium-potassium ATPase pump is also linked to the functioning of the sodium-calcium exchanger. So, there is another transporter that is sodium-calcium exchanger that is linked to the functioning of the sodium-potassium ATPase pump. So, with the inactivation of the sodium-potassium ATPase pump, there is increased concentration of sodium and also the reduced activity of the sodium-calcium exchanger leads to increased concentration of calcium. So because of increased concentration of calcium, there is positive inotropic action of digoxin which increases the cardiac output and this accounts for its mechanism of action and a positive beneficial action in heart failure. But excessive accumulation of calcium is detrimental. It leads to adverse effects such as tachyarrhythmias. So how is it possible? This is because of delayed after depolarization. So excessive calcium concentration, excessive intracellular calcium concentration leads to delayed after depolarization. So premature ventricular contractions because of excessive calcium leading to delayed after depolarization. Also because of increased calcium concentration, there is triggered activity. So there is triggered activity. This leads to ventricular tachycardia and ventricular fibrillations. To enhance automaticity, triggered activity leads to ventricular tachycardia, ventricular fibrillations. Now the next mechanism is enhanced vagal tone, increased parasympathetic nervous system stimulation, increasing the release of acetylcholine. So increased acetylcholine release slows down the AV nodal conduction and this can cause bradycardia or decreased heart rate, AV nodal block and sinus arrest. So these are some of the characteristic features of digoxin toxicity and bradycardia is an early sign of digoxin toxicity. To be noted that if high vagal tone is accompanied by increased automaticity, so increased automaticity at the same time high vagal tone, this can lead to paradoxical arrhythmias. What it means is Because of high vagal tone, there is AV nodal block, and because of automaticity, there is atrial tachycardia. So atrial tachycardia with AV block is highly suggestive. It is classic of digoxin toxicity. Atrial tachycardia because of automaticity, AV block because of high vagal tone, characteristic of digoxin toxicity. Electrolyte imbalance also plays a role in arrhythmias. For example, hypokalemia, which is common in digoxin toxicity, it enhances the binding of digoxin to sodium potassium ATPase, increasing the risk of toxicity. So hypokalemia, hyperkalemia and hypomagnesemia. Hypomagnesemia increases the susceptibility to arrhythmias, and hyperkalemia occurs in severe digoxin toxicity. So it occurs because of massive pump inhibition. So hypokalemia is common, it is an early sign of digoxin toxicity, but hyperkalemia occurs in severe digoxin toxicity. Hypomagnesemia also increases the susceptibility to arrhythmias, and another electrolyte imbalance is hypercalcemia. So to be noted that hypercalcemia also increases the risk of toxicity. To sum up the different types of arrhythmias, sinus bradycardia is an early sign. It is a common sign of digoxin toxicity. The second one is AV nodal block because of high vagal tone, which decreases the conduction to the AV node, leading to AV nodal conduction delay and sinus arrest. The third is a classic case of digoxin toxicity where there is atrial tachycardia and AV nodal block. So high vagal tone, AV nodal block is associated, it is combined with atrial tachycardia because of automaticity. So automaticity plus increased vagal tone leads to atrial tachycardia and AV block, which occurs in severe digoxin toxicity. Ventricular ectopy, that is ventricular bigeminy, as I have mentioned, the delayed after depolarization leads to premature ventricular contractions, bigeminy, and ventricular tachycardia and ventricular fibrillations can be life-threatening, and it usually occurs in severe digoxin toxicity. So how to treat digoxin toxicity? First, immediate steps are stop digoxin. As we know that digoxin is a culprit for this toxicity, so stop or discontinue digoxin. Assess airway breathing and circulation. Third, obtain the serum levels of digoxin. Electrolytes play a very important role in enhancing digoxin toxicity. So potassium, calcium, magnesium levels need to be monitored. Renal function needs to be monitored because digoxin is excreted through the kidney. So renal function examination is necessary. ECG, because digoxin is associated with cardiovascular manifestations, so ECG is also required. Next is activated charcoal should be given orally to inhibit or reduce the absorption of digoxin. In terms of electrolyte management, hypokalemia and hyperkalemia can occur with digoxin toxicity. Hypokalemia enhances the binding of digoxin to sodium potassium ATPase pump and increases the risk of toxicity. Whereas hyperkalemia occurs in severe digoxin toxicity occurs because of massive pump inhibition. So hypokalemia should be treated by giving potassium supplements. Do remember that IV calcium should be contraindicated, should be avoided in hyperkalemia. So hyperkalemia needs to be treated. It occurs in severe toxicity. And how do we treat hyperkalemia? By giving insulin and glucose, because insulin promotes the entry of potassium into the cells, reducing the potassium levels and treating hyperkalemia. Sodium bicarbonate should be given because hyperkalemia is also associated with metabolic acidosis. So if metabolic acidosis is there, so sodium bicarbonate should be given. Hemodialysis in case of refractory hyperkalemia. So hemodialysis to be done in refractory hyperkalemia. So how do we manage arrhythmias? Now there are two types of arrhythmias, bradyarrhythmias, tachyarrhythmias. So bradyarrhythmias, IV atropine is the drug of choice in case of bradycardia or sinus arrest. Also temporary cardiac pacing may be needed. Avoid beta blockers and calcium channel blockers because they inhibit the contraction, cardiac contractility, and they can exacerbate the arrhythmias, the bradyarrhythmias. When it comes to ventricular arrhythmias which are life-threatening, so in case of ventricular arrhythmias, do remember that lignocaine or lidocaine is the drug of choice in ventricular arrhythmias. It is given intravenously. It is a class 1 antiarrhythmic agent. So IV lidocaine, the drug of choice in ventricular arrhythmias. Alternative is IV phenytoin. Do remember that you should avoid amiodarone and procainamide as antiarrhythmic agents because they increase the risk of arrhythmias. Lastly, in digoxin toxicity, the antidote for digoxin toxicity is the digoxin specific antibody fragments, that is digibind. So digibind, that is digoxin specific antibodies available which acts as an antidote for digoxin toxicity, and this is used in severe digoxin toxicity. So with this we come to the end of this topic. We have discussed the signs and symptoms, the mechanisms and the treatment of digoxin toxicity. If you find this video useful, please like, share and subscribe. Thank you for watching.